You are listening to The Dish on Health IT, brought to you by Point of Care Partners, a leading health IT consultancy. Each episode will feature a rotating panel of senior consultants and guests who will talk about trends and innovations in health IT, while also highlighting how organizations can leverage these advances to solve their business problems. In this episode of The Dish on Health IT, we explore interoperability from the clinician and provider perspective, what it looks like at the point of care, and how those experiences shape standards. Host Tony Schueth welcomes guests Dr. Julia Skapik and Dr. Stephen Waldron from the HL7 Da Vinci Project's Clinical Advisory Council. They talk about why the clinical voice is essential in making interoperability work through standards. If you have ideas for future topics, email us at podcast@pocp.com or submit a form on our podcast page by visiting pocp.com, click on Insights in the main menu, and choose Podcast.
Let's get this party started. Welcome to The Dish on Health IT. I'm Tony Schueth, CEO of Point of Care Partners, and your host for today's episode. On the show, we serve up fresh perspectives and candid conversations on the challenges and opportunities shaping health IT. Today, we're digging into interoperability from the clinician and the provider perspective. We'll explore what it looks like at the point of care and how those real-world experiences inform standards development and implementation. Our guests share their perspective from their vantage point of serving on the HL7 Da Vinci Project's Clinical Advisory Council. The two leaders joining me today both bring deep clinical expertise and a front row seat to the council's work. Dr. Julia Skapik, member of the Clinical Advisory Council, SVP and Chief Medical Officer at PurpleLab and a practicing physician, and Dr. Steve Waldron, co-chair of the Clinical Advisory Council and Chief Medical Informatics Officer at the American Academy of Family Physicians. Julia, Steve, welcome to The Dish on Health IT. To start, could each of you introduce yourself and share your role on the Da Vinci Project? Julia, let's have you go first.
Sure. So I've been involved in Da Vinci in a number of ways for a number of years. I am still a practicing physician. I see patients in a primary care setting as a primary care provider once or twice a week, and then I do some emergency inpatient medicine. But I got involved with Da Vinci when I was a subject matter expert, advising Da Vinci on the Clinical Data Exchange Project, the goal of which is to maintain continuity in clinical information available at the payer level as the patient moves from plan to plan. I also worked a little bit on the DEQM, which is the electronic quality measures components of Da Vinci, as a member of the CQI work group. But I have been a member of the CAC for a few years now and love the opportunity to partner with payers and healthcare organizations and health IT vendors in making our work better and more data-driven.
Thanks. Steve?
Hi. So Steve Waldron, a family physician by training. I've been a clinical informaticist now for the last couple of decades, really working on interoperability. It's been great to see how much advancement we have made, but we still have a long road ahead of us. So that was one of the reasons that I agreed to co-chair the Clinical Advisory Committee through Da Vinci. At that time, it was with a fellow family physician, Stephen Lane. And it was a great opportunity for us to start to add a lot more clinician voice more purposefully at the higher levels of the organization. And it's been a great time working with a lot of great clinicians, from physicians like Julia to pharmacists to nurses. So it's been great.
Thanks to both of you for those introductions. That's going to be very helpful to our listeners. For listeners who may not be familiar, what is the HL7 Da Vinci Project and why was it created? Steve, you've been on the CAC longer than Julia. Let's start with you.
Sure. So when we go all the way to HL7 to start with, so as everybody probably knows, though, HL7 is a standards development organization, and you go through a consensus process, right, to create standards. And in a lot of those standards, you have multiple different ways that you could implement them to support several different variations of the use case, so that you don't have a standard that just won't really work in the real world. Which is great, but that also means then there's a lot of optionality there in the way that vendors and others can think about how you actually implement those. So there's been this effort over the last over probably even a decade. Maybe it's been about 15 years that I've been kind of involved with this process of what's called an implementation guide process, where you actually provide additional guidance and say, okay, for this specific use case, we're going to narrow down all that optionality and say, this is exactly how you need to implement this, with the hope then that when somebody implements it on both sides, that it'll just work without them having to talk to each other. So Da Vinci is a process that tries to create those implementation guides. And I wouldn't say tries, because we've already have several implementation guides that are out on the marketplace. But it brings together a lot of different stakeholders. And I think that's the real power of Da Vinci. So it brings together the payer community, the physician and provider community, and the vendor community to work together to solve these issues and say, all right, how do we constrain these great standards to make it such that they can be implemented the same way by multiple different individuals?
Julie, what would you add to that?
Well, I probably should have added to my intro that I'm the soon to be outgoing board chair of HL7 International as a disclaimer. One thing I'll add for why I see Da Vinci is really important and useful. So, as a former federal employee, having seen on the inside of how the government sort of makes its policy and regulation and technical requirements for external organizations, it can be very challenging for those folks to have a good sense of what the impact's going to be or what the most implementable or least burdensome approach will be. And I think one of the, light bulb things about Da Vinci was, hey, if all of us get together and agree on something that we can feasibly do as an approach to solve a known problem, then the government can use that to become an industry standard as they move forward with creating those regulatory requirements. And I think that's, been proven out many times in Da Vinci's history. The community actually defines the problem and builds the solution, and then the government's able to adopt that without necessarily paying for all of the work, and certainly without having to guess at what's going to be acceptable to all those involved. And I think because Da Vinci brings together those multiple stakeholder communities, the sense is that they sort of triangulate to a place of something that's actually doable for everyone involved. And so it's not like the payers will make the providers do this, or the providers will, force the vendors to implement something because they need it. It's sort of more of a collaborative space.
And they're leaders, right? They're leaders in each of those categories, those stakeholder categories. So what is the Clinical Advisory Committee's role within Da Vinci, and how does it complement the technical work?
From my perspective, if we're going to ask the provider community and healthcare organizations to be part of that workflow that's going to improve the way that both the payer administrators and the practices sort of successfully execute the operational parts of healthcare, then they really need to have a voice. And I think while there is certainly a clinical voice in the Da Vinci community, because clinicians tend to be very busy, the Clinical Advisory Council is a way of sort of getting a bunch of minds into the room who have similar perspective, and then asking a series of questions that can be used to inform the larger work of Da Vinci. Many, many hours of work a week goes into the Da Vinci project. And if you're seeing patients, or if you're running a association or advocacy organization for physicians, it's unlikely you're going to show up many, many hours a week. So I think clinical counsel is a way of bringing that voice in without making it impossible from a time commitment perspective.
Yeah.
Steve, what would you add to that?
Yeah, I think that's a great synopsis of the council. I would say from a strategic kind of standpoint, as Julia mentioned, there's a lot of clinician involvement in the individual use cases. But Da Vinci saw that there's another opportunity to provide that clinician voice kind of more at a strategy and organizational level. So in addition to being the co-chair for the Clinical Advisory Council, I also then, and my co-chair right now, who's Ed Yu, able to sit in on the steering committee meeting. So we're not able to vote, but we're able to say, well, we think that's not the best idea. Here's how the clinician perspective is probably going to say relative to that. And then it also gives an opportunity for us to bring together those like minds to create content that can support the efforts of Da Vinci. And I'm sure we'll talk about a couple of those efforts that we've done here recently, but I think that's the other kind of advantage of the council.
Those are really good points and valuable perspectives. So from the committee's perspective, what are the top clinical challenges that Da Vinci is helping to address? Steve, let's start with you.
Yeah, I think the biggest one is just how do we accelerate adoption of these implementation guides? So how do we make sure that we get really good real world testing as we're developing these implementation guides and finalizing them so that we know that they truly work in practice and we understand the workflows that are going to be needed to support those. Because in addition to the implementation guide, the vendors on both sides, either the payer or provider, are going to have to build additional product feature sets to really support the workflows for those clinicians. So making sure that that works, I think, is really, really important. And then just how do we accelerate the adoption? All our clinicians are like, we need this yesterday. We're kind of sick and tired of the kludgy kind of interoperability that we currently have and have to go out to multiple portals, and maybe every payer has done a fabulous job putting a lot of infrastructure in for their portal. My docs in family medicine see about 7 to 10 different payers in their mix of patients, so even just going to 7 to 10 great portals is still going to be burdensome for the docs. So we've been doing some work to try to figure out those that are actually innovating. What are they doing right, and how can we disseminate that out? And then what are some opportunities for Da Vinci and kind of the larger community to really drive better adoption of these implementation guides so we get to the true value of these, not just developing the standards, but actually see clinical and patient benefit.
Julia, you mentioned in your introduction that you are a practicing provider. What's your view on this?
Well, I can say I think they gave us about an hour of training in medical school about all of the world of like payer administration, billing, coding, everything. So I think it's frustrating as a physician to not have sort of the knowledge and insight that might be helpful in coming up with a better strategy of how to deal with some of these administrative workflows. And I think we have some added challenges of how those workflows do or do not, to Stephen's example, actually fit into the systems that we use and do that seamlessly. As a provider, I get very frustrated when it's like, I see the patient, we agree together on the treatment plan, and then the payer comes in later to say, oh, you should have talked about this instead, or you should have documented this. And because that's not something I had advanced knowledge into, I couldn't address it during the visit. So the opportunity to sort of have the insight and be able to, with the least amount of effort, sort of close those loops is really helpful. And I think, it's not unhelpful that the payer sends me a PDF telling me that they're concerned about my patient's statin medication adherence. But a PDF in a folder that I don't get paid to review for my work is not the way that I want that information. So I think there's a lot of innovation that we could use to work with the payers to actually improve things like utilization, avoid unnecessary visits, make sure the patient actually gets the meds that they're supposed to get in time. And I think that's what's exciting about the Da Vinci project, is that it does incorporate, those different challenges and components, even as, we're addressing some of the challenges for the payers.
Yeah, it absolutely. And the innovative component of it is something I know they've tried to build in from the very beginning. So in your view, Julia, what has been the most meaningful progress Da Vinci has made in bringing providers into standards development and implementation conversations?
Well, personally, I see that there's, I don't know, a perception of maybe even some animosity between payers and providers. And I think one of the great things about having those communities come together and try to work together is first the realization that I don't think there really is any kind of bad intent on either side. Everyone's just trying to figure out how to get the job done.
Right.
And when they're not talking to each other, they may be coming up with solutions that are good for them and not good for the people they're trying to work with on that. So I do think that is progress because that discussion and having more interaction between those groups is useful on its own. But I think what we're seeing in terms of the opportunity to reduce burden, I think even the work that the Da Vinci does on patient access can reduce burden on the provider because the patient, has a instinct to go to the office and ask them for help in navigating what's a horrifically complex system. And the more that we can put information in the hands of the payers, the more that takes some of the burden off of us, but especially around those workflows of, can we verify what the plan is? Can we verify who's covered under the plan? Can we find out what the rules are around the formulary or the prior authorization and do them in real time? Those things are all incredibly valuable. And I think to something that Steve said earlier, we're really starting to make substantial progress and we need to accelerate and make sure everyone can benefit that and not just the organizations that are sort of savvy and knowledgeable about Da Vinci, savvy and knowledgeable about integrating health IT, finding the payer partners and trying to get there faster. We don't want to leave the rest of the provider community behind. So we want to make sure people know that this is happening. People contact their vendors, that they work with their payers and try to ensure that that happens as fast and seamlessly as possible for them.
Steve, how about you? What do you think the most meaningful progress Da Vinci has made in bringing providers into the standard development and implementation conversations?
Yeah, I mean, I agree with Julia. I think just being at the table, I think is just critical. And as she mentioned earlier too, having kind of frontline clinicians participate in standards development is extremely hard. I've tried to get our members to participate multiple times, and either the conversation's too technical and they can't provide the right input, or they go on a couple of calls that have nothing to do with their input, and they're like, why am I wasting my time? So they don't stick it out to make that kind of conversation. So I think the fact that Da Vinci has done a couple of things. So one, making open invitations to docs to participate in that. So if you can, please do participate in that. But then also really engaging the health systems and large practices to be members of Da Vinci so that we really understand the business issues around the clinician perspective. And then lastly, I think really, creating the CAC so that there's kind of a formal representation of clinicians right into the steering committee and the operational committees of Da Vinci. So I think it's that multifaceted approach that they really tried to solve the problem. And is it perfect? Absolutely not. But I think they've really provided a significant effort to bring that clinician voice to the table and make sure that it's heard.
Steve, I remember when you and I first met, it was of a similar nature, where we wanted to bring the physician's perspective into the development of prior authorization standards on the pharmacy side. And we were saying some of the same things, but what's different is we were inviting you to task groups and you were participating in things sometimes that were, pretty detailed. And here the CAC, it seems like a more effective way to involve providers at the right level rather than a more detailed level. And of course, you're right, providers have a practice, patients to see. Yep. Let's go to let's move on. And there was a recent CAC report that highlighted provider concerns about usability and workflow alignment. How is the CAC helping to ensure standards actually fit into the real world clinical practice? Julia, since you're still practicing, once a week and on the weekends, different weekends, let's start with you.
Yeah, I mean, workflow alignment and usability to some extent are hard because, one size doesn't fit all, right? There are a lot of care settings in healthcare. There are a lot of, special use cases or specialty use cases. And so it's it's a process of trying to understand what the range of workflows are. I'm sort of lean expert trained. And one of the things we know about healthcare is actually a substantial amount of that variability may not have any intent or meaning behind it and may actually be a workflow that's not maximally efficient or effective. So I think whenever there's an opportunity to redo a process or improve a process, we should also be looking at, can that standardization of the workflow be beneficial for users separate from the new thing that we're doing about it? Like just being mindful about what the workflow is, making sure everyone is adherent to what that workflow is, thinking about how we're measuring the success of that workflow. Those components are all sort of built into the implementation projects, at least that we've seen and done through Da Vinci. One of the things that you'll always notice when you start to look at the workflow and changing the process is how important it is to do ongoing training, because every project I've ever done in quality improvement always identified people didn't know the thing they were supposed to be doing, and that's a major source of problems with the data that comes out of that and problems with the process. So, sort of building that into and monitoring that in systems that are able to sort of give you audit data to say, hey, we're concerned about this user. They're taking an awfully long time, or, where is the missing data coming from? Oh, it's maybe just 5% of the people. Can we highlight that for them? But as part of that training, it's also key to make it obvious to the care team that's basically acting as data entry analysts to some extent why and what is really important and has impact in terms of that data entry. Because if it's a random box with sort of a vague label, I'm not going to spend a bunch of my time clicking that box. But if it turns out that that box is something that is going to automatically look for any data from the prior authorization and check it against that, then I'll click that box all day long. And then I'll tell someone, hey, get rid of that box and just do that automatically. But, people are only going to really invest time in improving data quality if they understand what we're doing with that data and how. And I think another place that I think about this too is, when we look at prior authorization, because it's been a manual process, the movement to make it an electronic one is going to probably have some limitations. As with, say, quality measures, if you ask someone a question, they're able to do some interpretation and give you an answer that maybe is more nuanced than the question was specific. A machine can't do that. So one of the things I think we're hopefully going to see is actually the payers thinking about the prior authorization process, but also the content, to make the content more easily extractable from the data that's already there to further reduce that burden, right? Instead of asking me, did the patient ever take X medicine? Well, this might be the first time I ever saw this patient, right? So actually, a look at all of their former claims and EHR data is going to tell you much more about that than I know off the top of my head. So taking that kind of approach to sort of iteratively improving what and how we're doing these workflows to make sure that we're getting the right information and that people are involved only when absolutely necessary is, I think, really exciting. And I think the sooner we get to doing it, the faster we'll be able to make it better and better.
Steve, what's your perspective? How can the CAC help ensure standards actually fit into the real world clinical practice?
Yeah, so maybe let me separate out into kind of strategy of kind of why we did what we did, and then talk a little bit about some of the content, which Julie kind of already alluded to some of the great content that's in there. So if you think about the kind of diffusion of innovation, you see this kind of bell-shaped curve where on the leading tail, you have the innovators and the early adopters, and then you have this big group that's the early majority. And that's where we need to be able to see adoption of these solutions to be able to see it drive wide-scale adoption. So what we were thinking was, all right, since we're not seeing the early majority kind of in the mix yet, but we are seeing innovators and some early adopters start to try out and implement some of these IGs, could we have a conversation with those innovators and really understand what works, what any best practices that they had, and what are the challenges ahead that either they were able to overcome or they're still dealing with today. So in the report that we created, there's unfortunately a long list of those challenges and barriers and obstacles. But there's some real good themes there of, do you have the resources? Are you aware of the real value of that? Are you able to even know how to calculate an ROI for implementing these IGs? And then we said, okay, well, there's also this need to think about what are the opportunities then, not just for Da Vinci, because while we have a fair amount of resources at Da Vinci and a lot of great people, we can't do this by ourselves. So we created this kind of list of opportunities in there. So I think there's, again, like going back to the ROI, is there an opportunity to have somebody create a basic calculator? It's not going to be perfect, and it's not going to be somebody you just pick in and just pump your numbers and you're going to know exactly what you're going. But give you some sense of where the value is and how you could articulate that to people in your organization to make the decision. As Julie talked about kind of training, there's a big component of education, just educating providers and others on what these implementation guides are, what they do, how to implement them. And then there's also the notion of thinking about the developer community and saying, okay, well, we're talking about this interoperability between two systems, but once it comes into my system, there's other stuff that I'm going to have to do that are probably not in the implementation guide, right? So if we have that conversation with the docs, you talk about, for example, when we talk about prior auth, there's been a lot of discussion around, should we do real-time prior authorization? Should the clinician be part of the workflow? And there's people on one side that say like, well, we don't want to bother the clinician. There's all this data the clinician can't know or won't know. So it's just going to frustrate them, and they're going to say, screw this, I'm done with this. And we don't want to do it in real time because of, a lot of challenges to do that, right? And then from a clinician perspective, we're like, well, we don't want to have to see the patient leaves, then my back office comes to me and says, hey, we can't do this drug, but they want this other drug. Well, what should we do? It's like, well, I got to talk to the patient because that drug is a 3 times a day drug. And are they going to be able to do that or not? Or we think about something else. So I have to then call the patient back and do that whole workflow. So all that said, if you create the real-time clinician and back office workflow to be able to be part of the interoperability, that means the EMR is going to say like, all right, I need to triage this. So do I automatically always send it to the clinician and say, hey, if you can deal with this, deal with it. If not, do I create an infrastructure to then send that to the back office? Or do I even be more sophisticated and say, these 3 things are the clinical data they're wanting. Now, they're wanting to know if they were on an H2 blocker before you started them on the proton pump inhibitor. So let me just ask the clinician that because they're going to be able to answer that. But these other 2 questions are going to be back office. So I'm just going to route them into that. That's a lot of work. But if you don't think about that workflow, you're not going to get this, delightful experience for the clinician, which is, I think, one of the reasons that we want to be able to do this work in addition to making it better for patients. So.
Absolutely. It's interesting that you bring up prior authorization. What feedback are you hearing from clinicians about prior authorization automation efforts? And what do you see as the biggest opportunity for impact? Julia, let's start with you.
So as Steve had mentioned, there is a big curve in terms of people's both mindset and their capacity in terms of where they would like to be for prior authorization automation. I mean, the multi-care Regents pilot that was done already, I think, showed wild success from attempt at real-time automation of prior authorization. And so I think that that's really reassuring. In the system that I use as an outpatient, for example, we do have some kind of electronic prior authorization functionality, but I find that sometimes things seem to get stuck electronically and then I can't get them out of my window. They're just there like a graveyard of EPAs that won't disappear. So, it's going to be a process. And I think some people who have part of it are not going to be as satisfied as the people who went sort of straight through to the end desired product. I think people do have a hard time sort of imagining how it might work, right? for a prior authorization, you kind of need to start with an indication and not with a medication. So that's depending on the system, it may or may not line up with the normal workflow very well. But, I see a ton of GLP-1 inhibitor requests in my office, and I have a lot of Medicaid patients and people in managed care plans, and every plan has a different series of requirements. So if someone could just say, like, you can do phentermine or Contrave, I will stop the conversation about doing the injections and the side effects and all of that, and we will switch over to your insurance is not ready to pay for this. You want to try something else? These are your options. Just that in itself, even if the prior authorization still technically would need to happen in the manual way, would still be great because I could ward off as many of those as possible during the visit. So I think as people get a chance to benefit from any of that input, they're going to start to see like, oh, I want to go farther and farther with this because I could probably get rid of a lot of these requests if I had, a system that showed me the right information at the right time so that I could act on it. And I really do. I think that I had a patient once that had 5 unnecessary follow-up visits around a series of problems with the prior authorization. Like the patient came in once and then they end up coming in like 4 more times to deal with, decision making around the alternatives and whether or not they could do the alternative and having an issue with it. Like 5 visits, that it should have been 1
Wow.
visit.
Wow. Steve, you and I have been working on prior authorization for a long time, or at least I have, and you've been sort of giving us feedback from
Bring it
what
on.
the clinicians are saying. What are they saying now?
Yeah, and so prior auth is interesting. So, there's definitely a lot of administrative burden in primary care. And I think the volume in prior auth is not the highest as some of the others, but it is the thorn in the backside of members because a lot of times they're like, this makes no sense. It's like, why am I doing a prior auth on a generic drug? Why am I doing a prior auth to get testing supplies for a diabetic? It's like, I'm pretty sure we haven't solved and cured diabetes yet. So why every year do I have to do this? So it's those, in addition to the ones that, maybe still need to be there, that are really a challenge. And I think the other thing is one that Julia alluded to several times in her comments was partial solutions. So you get a solution that says like, oh, well, we'll let you know that this requires a prior auth or we're going to deny it. And we'll do that right away. So, yep, you can't get your GLP-1. Okay, well, do I have to guess what other options I could maybe think about getting as opposed to saying, like Julie said, like, here are the alternatives that we'll pay for and what you need to do. So don't just say no, but say, what are the options and give the doc the opportunity to make an informed decision. And then lastly, I think it's just the delay. So, I'm seeing the patient, why couldn't you have let me know right then and there? Because they feel like the technology is there to do that, which, technically it is, but it's not been defined in a way to make it standard. Again, why Da Vinci exists.
And it leads to genuine delays in treatment. Whenever these information, and this goes to eligibility and all sorts of other things, right? When the information is not the correct information, the correct place, and the correct format at the correct time, that leads to a patient not picking up their meds and going untreated. It leads to them coming back to the office with no improvement in their condition. Like, those things have long-term impacts as well, and they just drive costs unnecessarily in the health system.
Yeah,
Because then it comes to the ER because they, ran out of their generic insulin or they ran out of their blood pressure medicine.
Yeah. Yeah, I ran into that. So I had to have pancreatic enzymes. So, doctor ordered them for me or whatever, and I was all these symptoms, and then I go and it's like, it's going to have to all this prior auth stuff, but you can buy them if you want them. It's $2,500. So, I mean, luckily for me, I have the means to be able to say like, all right, well, I'll do that. Then I'll I'll worry about getting reimbursed or at least pull off my deductible later. But if somebody, most people are not going to be able to do that. And the symptoms I were having were horrible. And they were completely solved by taking that drug. And I understand it's very expensive, but it just makes perfect sense when you clinically look at why I needed that drug. It was, and as soon as they looked at it, they were like, yeah, you need that drug. And they've been paying for it ever since. But
wow, thanks for adding that story. It's always good to get, real world perspectives brought into this discussion. Let's switch gears a little bit and let's talk about policy and regulation. So recently there was a CMS digital ecosystem pledge that several organizations made, and they're shaping some of the direction. Steve, how do you see that working? How do you see that playing out?
So I think words and pledges are great, but actions are where the money's at. So I think, again, I don't want to discourage people from saying like, yeah, let's all get together, let's pledge and figure out what we're going to do and all work together. I think that's great. But I think a lot of clinicians are going to be out there going like, okay, well, you said you're going to do some of this stuff in the past and never quite got there. So I think the clinician community is going to be a little bit hesitant to say, oh, it's great. Look, everybody's pledged to do this. And then the last thing I think is there's been so much effort now in interoperability. How does it all work together? So how do you do some of the traditional HL7 standards versus FHIR? How do you do QHINs? How do you do TEFCA? Now we have this pledge. Now you have aligned networks. And it's just like you have all these different pieces, and as opposed to saying, let's all work together on a common rail that we're all working toward. So that's the other thing that I think about when I think about all these kind of opportunities. But again, I think having the focus on interoperability is really important, and I'm glad to see that they're doing that.
Julie, what's your take? How does the pledge shape the direction of Da Vinci from your perspective?
So when I worked in the federal government, and this was around meaningful use stage 2, I discovered there are a lot of things which the government asked for attestation. And many people over time were asking me, why are we doing attestation? What does attestation change in terms of outcomes? And I think in the sense of checking a box, it doesn't change anything. And, people can check the box all day long. All that does is add a bunch of paperwork that hasn't really added any insight into how well or consistently or easily people are doing something. So I think to Steve's point about pledges, they're great, but we need to move to objective evidence of impact. And I think if the motivation for people continuing to advance interoperability and the digital openness of health data in a safe and secure way, and the government's not going to throw money at it, there has to be alignment with business cases. I think CMS 0057F is actually a good example where there's sort of a combination of business case alignment and regulatory alignment. But, if we can create much more clear objectives and then, work with the support of the government to reach those timelines and specific outcomes and measure our success, I think we'll accelerate things more quickly and do that in a more collaborative way that's an even playing field for everyone involved. We'll hear more voices. We'll get there faster.
Well said. Well said. What about regulations on price transparency, quality measures, and value-based care in alignment with incentives? How does Da Vinci's work support or intersect with that work? How does the progress in these areas impact clinicians? Julia, let me ask you that first.
Yeah, so I'll say full disclosure, my day job for PurpleLab is a company that does claims data analytics at scale. And so we actually have some products that are intended to help healthcare organizations, payers, even people who have interfaces down to the patient level understand some of these things. We supply data for quality scorecards for providers and healthcare organizations. We support price estimates and value-based care models like Team. And we have a trusted price intelligence tool that allows you to say, how much does this cost at this place and this place? So a lot of those, I'm not an entirely objective person to speak on this, but I think those things really do help people to make more informed decisions. And because we have this massive amount of processing power now at our fingertips, easily able to be increased or decreased using services we can get to in the cloud, we should be integrating all of these data types to make smarter decisions all of the time. And that should be something that we can surface to the care team, something we can surface to the team negotiating the contracts, something we can surface to the patient, so that those decisions can help to motivate people on the business side and also on the operations of healthcare side to make all of that work better for everyone. And I think Da Vinci's work supports that because it provides both infrastructure and consistency in how that information is encoded, which allows us to really say that, plan A, B, and C and healthcare organization D, E, and F, those things can be compared fairly and not sort of based on, well, they said it was this, they said it was this, because that's the way we've approached some of these quality things in the past.
Yeah. Well, as a patient, I always say that we're all patients, right? I would love to have some of this information as well directly to me. Steve, what's your take on that? What about regulations on price, cost transparency, quality measures, value-based care, and alignment of incentives? How does Da Vinci's work support or intersect with that work?
Yeah, so I don't have the same potential biases Juliet laid out, but I completely agree with what she said. So I don't think there's much bias in what she said, actually. But price transparency is really important. I think it's important from the standpoint of docs would love to be able to direct patients to the highest quality, low cost care. I mean, if it was an easy one to say like, here's 3 GI docs and here's their quality score and here's their cost score, great. I'm going to send you right to this person because they have the best, QPR, as they say, quality price ratio. But I think you also have to start to think now about access as well. So now I need to know what's the time, because now if everybody's directing them to those individuals, are we having an access issue? So then maybe the access thing makes it important. But I think also make sure that's transparent, because clinicians are very competitive. So if their quality is not as good as their colleagues, they're going to do everything in their power to get it better than their colleagues. So making that transparency is really, really important. And I think there's probably a need for regulations in this space to push the market to do that, because it's not going to be easy and it's going to mean revenue problems for some individuals in the marketplace. So I do think that's the case. As I think about Da Vinci, though, I think there's probably a short and a long-term opportunity. The short term is to have these implementation guides that support the exchange of electronic and digital quality measures as they're being developed. But I think the real value is our work we're doing in the clinical data exchange and provider data or payer data exchange, CDX and PDX as they're called. If you actually are able to start to exchange clinical data, we can start to get away from just looking at claims data, but actually starting looking at clinical data. And the hope is that we'd have even more robust quality measures that have much more meaning to patients and their health and their wellness. So I think that's the long-term vision, that some opportunities with Da Vinci. And again, I think when we talk about CDX and PDX, we're not talking about quality measures, but in my view, I see that's where we're have an opportunity to head to.
Yeah, and Tony, I was surprised. I think it was through Da Vinci that I learned that payers are increasingly sort of having their own staff to try and manage and coordinate care. And as a person who has care coordinators also in their office, the question I'm asking is, who's coordinating the coordinators? Like, there's no communication between those two groups of people. They're looking at two totally different sides of the elephant, right? One of them's looking at the claims, one of them's looking at the EHR data. If we can use standards to bring those two people to easily interact and support each other and to complement those separate data sets with each other, that is a game changer, like an exponential amount more to be learned, and a much more efficient way for payer to coordinate certain things, office to coordinate certain things, even to coordinate with other offices coordinators. Like, that's what we need to really make a turn on the cost and on the burden of, administering care at an individual healthcare facility.
I love that idea. I'm going to pass along to Alex. We need a use case on coordinating with the coordinators. I love that. Let's go to final thoughts or calls to action. What would you like our listeners to take away from this conversation? Steve, let me go to you first.
Yeah, so I would think it's the promise that we have to really make a big difference in interoperability. And I would ask any clinicians or other folks that are in there, engage when you can and where you can. I understand that you can't do everything, but even if it's just really understanding what's available so that inside your organization, you could advocate for you and your fellow clinicians to have your organization start to try to implement some of these IGs to get some of the value out of it that we're seeing with our early adopters of these IGs. So I think that's probably the most important thing is just engage. And I would say that Da Vinci does try to do a great job of providing some education. So we have both kind of business tracks that are more focused on folks that don't have a technical background. And then we have technical tracks for folks that are like me, really nerdy and love to get into the gory details of things. So I think we have education that would fit your need to get you that awareness so that you could be that self-advocate.
Julia, what are your final thoughts or calls to action? Any more use cases that you can think of, or what else should everybody think about?
Well, I think if you had been in the room in Da Vinci maybe 5 or 6 years ago, we were in an early place when it came especially to prior authorization. That is going into effect in, just over 12 months from now in the United States. Mm-hmm. And so from a strategic perspective, it is really smart to be looking at these things really early on. Not only does that give you the chance to say, hey, you're about to fall off that cliff over there. Can you turn back to the main road here? Or can we incorporate some of these other needs of healthcare organizations into this process? But also it gives you the chance to look at your own organization's exchange policies, practices, and success in some of these areas and think, is there a better way of doing this? The final thing I would say is, even if your organization doesn't have a person who can sort of be deeply involved with the work of Da Vinci, you probably have a bunch of vendors, you pay them money, and a lot of payers who pay you money. And so reaching out to them and saying, hey, what are you doing with Da Vinci? Are you going to be supporting these things? Are you piloting them early? Like, I want you to be there on my behalf because, I represent you or provide a service for you or vice versa. And if we all are going to be at that front edge, then I need you to be in that room. I think that that's powerful. And it also creates some expectation and conversation about where the future is heading for, the three of you as a triad.
I love it. I love it. Well, we're really to the end of this. I want to say a huge thanks to Dr. Julia Skapik and Dr. Stephen Waldron for joining me today to share their thoughts on interoperability and the Da Vinci Clinical Advisory Council. To our listeners, if this episode sparked any new ideas about the role of clinicians in shaping standards and interoperability, share it with your colleagues. Also, share with them Da Vinci and encourage them to get involved. And don't forget to subscribe to the Dish on Health IT wherever you get your podcasts. So until next time, Health IT is a dish best served hot. Thank you.
Is it a challenge to stay on top of interoperability regulations and the flurry of activity with FHIR accelerators? Email us at interopoutlook@pocp.com to learn more about our Interoperability Outlook subscription monitoring service.